So now we are starting with orthopedics or complete orthopedics for Neet PG. So this will be in two parts. This is the first part, and second part I will upload within 1 to 2 days. Okay. So we will revise with the help of the MCQs. So now if you see, there is a 45-year-old male who sustained a very high motor accident with extensive soft tissue damage with visible bone fragment of tibia and wound measurement is 15 centimeter. Circulation is adequate. This is very important. But after surgery, surgeon found that the soft tissue envelope is inadequate to cover the exposed bone. What type of Gustilo-Anderson classification this is? So actually it is asking about the Gustilo-Anderson classification. So first we have to understand what is the Gustilo-Anderson classification is basically for the open fracture. Open fracture. So it is divided into three types: first, second, and third. And the third part is divided into again three types: A, B, and C. So if the length of the wound on the skin is less than 1 centimeter in an open fracture, it is Gustilo-Anderson type 1. If the length is more than 1 centimeter but less than 10 centimeter, it is Gustilo type 2. And if it is more than 10 centimeter with extensive tissue damage, if there is it is more than 10 centimeter with extensive tissue damage, it is type 3. Now, how will we classify it into A, B, and C? A means injury will have extensive tissue damage. In B, it will be for, remember, break the periosteum. So periosteum will be bricked. And with C, remember the circulation. That means there will be some kind of circulatory problem. That is, distal pulses will not be palpable or there will be a massive bleeding. So in the question, they will give some kind of circulatory problem. So if circulation is involved, it is 3C. If periosteum breakage is given, it is 3B. And if it is said that it is segmental fracture, it is A. So this is how Gustilo-Anderson classification is done. Now, we can also see the treatment. Remember, in all of these fractures, we will give antibiotic, we will do the debridement. This will be done in all the Gustilo-Anderson. But then there is third thing that is known as either we will do the close reduction, internal fixation, or open reduction, or just we will put an external fixator. Okay, so in all of these, we will give an antibiotic, we will do the debridement. Now, in third class, since there is a very extensive tissue damage, you cannot open it and do the definitive repairment. Although the definitive repairment will be the open reduction and internal fixation, but you cannot do at that point of time because there is extensive tissue damage. So what you do is in class 3 injuries, you just put an external fixator. You just put an external fixator, and after when the tissue damage subsides, then we do a open reduction and internal fixation. That is, through surgery we open the skin, and then with the help of the implants we do the internal fixation. But initially we cannot do internal fixation, so we put a external fixator. Now, very important point, when we are treating all these fracture initially, then till 3A, surgeon can easily close the defect with the help of the surrounding tissue. Please remember, it is a very important thing that till 3A, surgeon can very easily close the fracture site with the surrounding tissue. But from 3B and 3C, flaps are required. So whenever it is given that the surgeon is not able to completely close the defect with the help of the surrounding tissue, then please remember the classification is above than 3A. It may be 3B and 3C. If the circulatory problem is there, it will be 3C. If the circulatory problem is not, it is 3B. Now, if we see again, 45-year-old male sustained high energy motor accident with extensive soft tissue damage with visible bone fracture. Wound measurement is 15 centimeters. 15 centimeter, it is a 3, class 3. Because more than 10, it is class 3. Circulation is adequate. That means it is not 3C. Now it can be 3A and 3B. But after surgery, surgeon found that the soft tissue envelope is inadequate to cover the exposed bone. That means it is 3B. So this is gustilo-Anderson classification is it is 3B. So remember gustilo-Anderson classification in this way, so you will able to solve every question. Now identify the external fixator. Just I have told you there are a lot of external fixator. Now this is an external fixator, which is this is a ring external fixator, or better known as Elizaro external fixator. Now these two, you are seeing there are pins and the rods. These are the rods, and this is pins. So this is pin and rod external fixator. Here the pin and rod is present in a single plane. So this is known as single or monoplanar rods and pin external fixator. Here there are two planes, one plane and opposite plane, that is opposite 180. So this is biplanar. This is biplanar rods and pins external fixator. And this third one I have told you, this is the ring fixator or the known as Elizaro fixator. And the fourth one, this is, you are seeing there is a ring fixator plus there is also a rod fixator. So this is known as hybrid fixator. So in NICT, once a question was asked, out of these four external fixator, which has the max, which is most stable? So hybrid external fixator, that is ring plus rods and pins, has the maximum stability, followed by the ring external fixator, followed by the biplanar. And if they ask which is the least stable, then answer will be monoplanar rods and pin external fixator. Okay. Now, this is a question. True for closed reduction and immobilization. What is closed reduction? Closed reduction means, for example, if there is a Colles fracture. In Colles fracture, what happens? That there is a fracture of the distal radius and the distal portion moves dorsally. And in a Smith fracture, the distal portion moves ventrally. That is on the palmar side. If the distal fragment moves towards the palmar side, this is known as the Smith fracture. And if the distal segment moves to the dorsal side, that is known as the Colles fracture. So in all these fractures, without giving incision, you externally reduce the bones and you do not give an incision, you do not open. So this is known as close reduction because you are not opening, you are not giving skin incision. And then you put a plaster of Paris, that is plaster, that is below elbow plaster. So this is known as immobilization. So what if I ask you what is the treatment for radius, distal, extra-articular, that is Colles fracture and Smith fracture? So you will say that is close reduction and immobilization. So now they are asking the basic question. Close reduction and immobilization involves surgical incision to realign the bone. So this is wrong. We don't give surgical incision. Immobilization is not necessary. No, it is very much necessary. For example, in Colles and Smith fracture. Close reduction is a non-surgical method to realign the bone. Yes, it is a non-surgical method. Immobilization should be discontinued immediately once the fracture is reduced. This is false. Actually, the immobilization is started once immobilization is done with the help of the plaster, once we are able to realign the bone or once we are able to reduce the bone. So this is done in cases of two fracture, which you have to remember. One is the Colles fracture and other is the Smith fracture. In these two fracture, you use close reduction and immobilization. Now, then there is the second term by the name of close reduction and internal fixation. Here also, you do not give incision, you do not open the bone, you externally reduce the bone and then through the skin, you put either some nails or some pins. For example, the characteristic example is fracture femur, fracture tibia. In case of tibia or femur, we externally reduce the bones and then we put pins. We put nails, for example, tibial nails or the femoral nails. We know that there is PFN, that is proximal femoral nail. Okay. So close reduction internal fixation is primarily used for the treatment with extensive soft tissue damage. No, I have told you with extensive soft tissue damage, that is in class 3, the definitive treatment is open reduction in internal fixation. But initially you cannot do it because of extensive tissue damage. So this is wrong. Close reduction involves making a surgical incision to, so this is also wrong. Incision is done in open reduction. Internal fixation involves the use of metal plate, screw or rods to stabilize after the closed reduction. Yes, this is right. First we reduce the bone externally and then we can use all these things. Close reduction internal fixation is commonly used for the open where infection risk is high. No, I have told that is in class 3 where extensive tissue damage, or if there is a circulatory problem, that is artery is damaged, or if there is a high infection, the definitive treatment is open reduction in internal fixation. But since we cannot do it initially, we just put a external fixator, and the definitive treatment in the form of ORIF is done afterwards. Now, what is true about ORIF? Now let's see. Used to treat fracture with minimum soft tissue injury. No, fracture with minimum soft tissue injury. It is used in case of fracture with maximum soft tissue injury. ORIF involves surgical process to realign bone fragment and stabilize them with internal hardware. Yes, this is true. This is the exact definition of ORIF. ORIF is contraindicated in patient of infection or compromise. No, in compromised blood supply, you have to open then and there. So this is also wrong. ORIF is exclusively used for distal radius fracture and not for other. This is wrong. Okay. So this was regarding some question that has been asked regarding the basic things. Now, if you see this, what is the primary advantage of using this below page? First is risk of infection. What is this? So this is LCDCP. That is low contact dynamic compression. Why it is called low contact? Because of these depressions. So because of these depression, the pressure on the bone, the pressure on the circulation is less. So bone healing is very good. It is generally used in case of upper limb fracture in ORIF, that is open reduction internal fixation of upper limb like radius fracture, ulna fracture. If these pits are absent, then it is known as a simple DCP, where the chances of damage to the arteries and periosteum is more. Here, because of these pits in LCDCP, the damage to the artery is less. So what is the primary advantage? Increased risk of infection? No, it can never be enhanced stability due to increased contact. No, reduced soft tissue irritation and better blood supply. Yes, this is the answer. High cost? No, it can never be an advantage. So answer is C. Okay. This is a simple DCP. That is, there are no pits here. So it has high chances of damage, although it cost is less, but it has high chance of development of, it can damage the blood circulation and it can also damage the periosteum. Therefore, which is preferred? LCDCP, low contact dynamic compression plate is preferred. Now, you have in trauma, this question can be a 54-year-old male patient developed injury and his GCS is as follow. Eye opens only to the pain. So we know in GCS we have E, V and M. E maximum is 4, verbal response maximum is 5 and motor response is 6. So I, the lower the value, the more pathological state of the patient is there. That is, there is high chances of risk of death in patient. So GCS is directly related to the prognosis. The minimum value of GCS is 3, maximum is 15. A value of 8 or less requires intubation. A value of 10 with decreased mean arterial pressure less than 65 also required intubation. So these are the questions. So IE 4 means that patient is normal, like is or she is opening eyes. E3 is that is patient is opening eye on command. E2 the patient is opening eye on pain, and E1 means that patient is not opening his or her eye. So always the best option is taken. So here eye opening is done on the pain. That means it is E2. Now verbal. In verbal, V5 means that patient is talking normally. In V4, the patient is confused. In V3, patient is saying inappropriate 3, that is inappropriate. And in V2, patient is saying incomprehensible things. And in V1, patient is not saying anything. So this is incomprehensible. That means it is V2. Now motor response I'm telling you, M6 means it is normal motor response like a normal person. M5 means localization of pain. For example, if I will give the pain at this area, the patient hand will come like this to my hand and he will remove my hand. That means he can localize the pain. That is M5. M4 is flexion withdrawal. Flexion withdrawal, that means whenever I will put pain like this, the patient will show like this. Okay, he will not able to pinpoint the pain area, but he will do a flexion response. What is M3? M3 is flexion on pain. And what is M2? Extension on pain. And M1 is no movement. So now if you see the motor response, flexion to pain on right side and pinpointing the pain on left side. So which is better? On the left side. So better response is always taken. So he's pinpointing. That means it is M5. So answer will be E2, V2, M5. So answer will be E2, V2 and M5. So they can ask you a question based on GCS. The most common nerve involved in shoulder dislocation. Shoulder dislocation में most common nerve कौन से involved होगी? The most common nerve involved in shoulder dislocation will be axillary nerve. Axillary nerve basically supplies two muscles. Axillary nerve supplies one muscle that it supplies is deltoid, and the second muscle it supplied is teres minor. Deltoid main function is abduction from 15 to 90 degree. And teres minor is a weak external rotator of shoulder. So in axillary nerve damage, there is always, and it also takes sensory sensation from the deltoid areas like this area, this area. So axillary nerve damage will have problem of abduction from 15 to 90 degree. Plus there will be a problem in the external rotation of the shoulder. So this we have to understand. Axillary nerve contains fiber from C5 and C6. Very important point which has been asked. In axillary nerve damage, it is the most common nerve involved in the shoulder dislocation. It supplies deltoid muscle and teres minor. Deltoid is abductor from 50 to 90 degree, and it is weak, and teres minor is weak external rotator of shoulder. Please remember, teres minor is a muscle of rotator cuff, but deltoid is not a muscle of rotator cuff. Okay. So now, most common type of shoulder dislocation is anterior dislocation, and axillary nerve is damaged in anterior dislocation. In posterior dislocation, axillary nerve is generally spared. Therefore, if someone asks you which is the most common nerve involved in shoulder dislocation, you have to take that dislocation as anterior dislocation, and axillary nerve should be marked. Now, this area of the deltoid area, there is also loss of sensation when axillary nerve is damaged. And this is known as regimental badge sign. So whenever there is loss of sensation from this area, so they have already asked that regimental badge sign is seen in. So you have to answer axillary nerve. They have asked this question earlier. Now they can show you in a diagram that there is a after anterior dislocation of the shoulder, a nerve is damaged and there is loss of sensation from this area of the shoulder. What is the sign known as the sign is regimental badge sign. RE regimental badge, BAD badge sign involved in axillary. Okay. So this is the question. In the shown area, there is loss of sensation. Which nerve is involved? What is the sign known as? So we know that is the nerve involved is axillary nerve, and the sign is the regimental badge sign. And it can be a complication of shoulder dislocation. Okay. So this is a regimental badge sign. This area, axillary nerve sensation, damage in shoulder dislocation. This can lead to the regimental badge sign. Axillary nerve supply. Axillary nerve supply is the I have told you teres minor muscle and deltoid muscle. Deltoid is the abductor and external rotator of shoulder. It's the teres minor. Most common nerve injured in shoulder dislocation and regimental badge sign over deltoid region. The most common nerve injured in shoulder dislocation, I have told you, that is the axillary nerve. This you have to remember. Because whenever not specified, you have to take shoulder dislocation as anterior because most common it is anterior. Most common hip dislocation is posterior. Most common nerve injury in posterior hip dislocation is sciatic nerve. Okay, most common dislocation in cases of congenital hip dislocation, that is the posterior. Okay. Which test is done for shoulder impingement syndrome? So here you have to understand some important points. Now, so there is 0 to 15-degree abduction, then there is 15 to 90-degree abduction, then there is greater than 90 degree of abduction. This is related to abduction. So abduction had to be divided into these three sides: 0 to 15 degree, 15 to 19 degree. So 0 to 15 degree is done by supraspinatus muscle. Supraspinatus. 15 to 90, I have already told you, deltoid. And if it is more than 90 degree, if there is a pain, that is known as painful arc syndrome. If there is pain, if the patient is abducting more than 90 degree, that is known as painful arc syndrome because patient is not able to make the complete arc, or it is also known as impingement syndrome because questions have been asked in both the form, impingement syndrome. Now, if the patient is not able to abduct the arm between 0 to 15 degree, that means he is not able to initiate abduction. That means there is a complete tear of supraspinatus. Please remember, it is complete tear. In cases of complete tear of supraspinatus, you will have a problem in initial abduction, that is 0 to 15 degree. But if there is a partial tear of supraspinatus, that means partial tear of supraspinatus, then patient will develop painful arc syndrome or impingement syndrome. So whenever they ask you painful arc syndrome or impingement syndrome, complete tear of supraspinatus, partial tear of supraspinatus, so your answer will be partial tear of supraspinatus. Okay. Which is the nerve which supply supraspinatus muscle? Supraspinatus is supplied by the suprascapular nerve. Suprascapular nerve. Now, in cases of shoulder impingement syndrome, they are asking which test you have to do. Now, so we'll see each. Now, so complete tear of supraspinatus will lead to the 0 to 5 degree abduction problem, and painful arc syndrome or impingement syndrome will be there if there is a partial tear or if there is a calcification in old age in the supraspinatus, or there is tendinitis of supraspinatus. So if there is tendinitis of supraspinatus muscle, partial tear of supraspinatus, or if there is a calcification in old age, all these will lead to painful arch syndrome or impingement syndrome, and complete tear will lead to initial abduction problem. Now, Lachman test. We will study this. Lachman test is done for anterior cruciate ligament problems. AC means anterior cruciate ligament. Anterior cruciate ligament. And H for hypersensitive. So it is the most sensitive test. and the angle at it is done at 20 to 40 degree. For example, there is also a test that is anterior drawers test, but anterior drawers test you cannot do in the acute injury. Anterior drawer test has to be done at a 90-degree knee position. Okay, so Lachman test cannot be the answer. Now there is Hawkins-Kennedy test. Let's see. Then there is Mac-Murray test. Mac-Murray test we will see is done for the meniscus injury, medial meniscus and lateral meniscus. So you can remember from M and M. So Mac-Murray test is done for meniscus injury, and Finkelstein test we will see. Finkelstein and Eckhoff test is done for decurvent tenosynovitis, which involved inflammation of two muscles. One is abductor pollicis longus and the second is extensor pollicis brevis. So that is decurvent tenosynovitis. This has been asked multiple times. It is, you can remember it, you remove I from the IPL, that is APL, so that is abductor pollicis longus and extensor pollicis brevis. So inflammation of these muscles will lead to decurvent tenosynovitis, and the test used to elicit it that is known as Finkelstein test, and the other test is Eckhoff's test. That is EICHOFF, Eckhoff test. Eckhoff test and Finkelstein test. So this cannot be answered. So the answer is Hawkins Kennedy test. How you do Hawkins Kennedy test? You put the shoulder in front of you, then you flex, and then you ask the patient, and then you ask you put you the examiners put his hands like this and ask the patient to elevate the shoulder, and patient feels a lot of pain. This is known as Hawkins Kennedy test done for the painful impingement syndrome. So I've told you 0 to 15 degrees supraspinatus nerve complete tear. So no 0 to 15 abduction. So if they ask complete tear, but if it is 90 and above, that is known as painful arc syndrome or impingement syndrome. And this is the partial tear of the, this is the partial tear of supraspinatus, or there can be tendinitis or can be calcification. And between 15 to 90, deltoid, which is supplied by the axillary nerve, which we have already discussed. In lift off test, which of the following stability is test? Now, please remember muscles of the rotator cuff. These are four muscles which we already know by the SITS. Sits. S is for supraspinatus, which we have just seen. I is for infraspinatus. T is for teres minor, and S is for subscapularis. Subscapularis. So now please remember this subscapularis muscle. It is written subscapularis, but it is not present below the scapula. It is present anterior to the scapula. It comes from the scapular fossa, and the origin is from the scapular fossa, and its insertion is on the lesser tubercle. And the main function of subscapularis muscle is internal rotation. It is the internal rotator of the, so it is the strongest internal rotator of the shoulder. So if there is a problem in subscapularis muscle, there will be difficulty in internal rotation. So what you will do, you will ask the patient to put his hands, to take his hands and take it to the back side. If there is a complete tear of the, if there is a complete loss of this nerve, this muscle, that is subscapularis, the patient will not be able to put his hand in the back. But if there is a partial tear in this subscapularis muscle, patient will able to keep his hand at the back. But when you will ask the patient to lift his hand against a resistance, and you will apply the resistance by putting your hand on his palm, the patient will not able to lift his hand. This is known as lift off test. So in complete tear of the subscapularis, which is a part of rotator cuff, the patient will not able to lift off his hand. And in case of partial tear, that is 30-40% subscapularis muscle tear, patient will not able to take his hand to the back, because taking hand towards the back involves internal rotation, and internal rotation is done by the subscapularis muscle. Subscapularis muscle arises from the subscapular fossa of the scapula, and is one question has been asked that in anatomy, that it is insertion is on the lesser tubercle. Okay. Now, then supraspinatus we have already discussed. The supraspinatus muscle is for the abduction 0 to 15 degree, and in partial tear it causes painful impingement syndrome. Now, this infraspinatus and teres minor, these are the rotator. I have told you that teres minor is a weak external rotator. Weak external rotator. So, weak external rotator, and the main external rotator is infraspinatus. Infraspinatus. Okay, so weak is infraspinatus. This you have to remember. Now, we will study the other test after some time. So, in the lift off test, so I have told you lift off test, that means subscapularis muscle. Which of the following stabilities test? We test the stability of subscapularis muscle, which is a part of the rotator cuff. So, shoulder instability, rotator cuff strength. Yes, we actually test the rotator cuff strength. Okay. If in the option they can also put subscapularis, because the main muscle that is in lift off test that we check is basically subscapularis muscle. Okay. Now, shoulder, I have told you the external rotator. There are two main external rotator. I have told you is the infraspinatus, and the weak external rotator is teres minor. Okay, infraspinatus is supplied by the suprascapular nerve, and teres minor is supplied by the axillary nerve. Internal rotator, I have told you the main internal rotator is subscapularis, and it is supplied by the, and the test is done with the lift off test. So, internal rotation, it is subscapularis muscle. Internal rotation, it is muscle of rotator cuff, supplied by C566 and lower subscapular nerve. This is not asked. Okay. Lift off test. This I have told you, lift off test. The two types of lift off test. Then external rotation is done by infraspinatus, suprascapular nerve. This suprascapular also supplies the supraspinatus muscle. And teres minor, which is the weak external rotator, is supplied by the axillary nerve. So all these MCQ point I have already explained. Now, a 35-year-old patient and history of trauma present with abduction and external rotation. Which dislocation it is? Now, this you always remember. Now, in shoulder dislocation, I have told you, just remember 4-5 points and all your question will be done. So, what is the most common type of shoulder dislocation? It is the anterior dislocation. Now, how the patient will present? The patient will present in the form of Amitabh Bachchan. For example, Amitabh Bachchan says, "Na, hey, kya re?" So he says, "Hey." So that means external rotation and abduction, just like the Amitabh Bachchan classical pose. So in most common shoulder dislocation is anterior. Most common presentation is abduction and external rotation. Then third, what is the treatment? How will you reduce? So it is through Kocher's method. Kocher, Kocher's method, and coach always is present in a team. So remember Kocher's method in the form of team, TEAM. T for you will apply traction, E for external rotation, A for adduction, and then M for medial rotation. And the fourth point you have to remember, which is the most common nerve involved. I have already told you, axillary nerve. What is the sensory areas lost? That is over deltoid, known as regimental badge sign. Okay, then there are three tests. One is Dugas test, DUGAS, Dugas test. Second is Calvé test, CALLAWA, Calvas test. And third is Hamilton Ruler test. And please, very important point, which is clinically helps you to differentiate between anterior and posterior dislocation is that in anterior dislocation, you contour is lost. This contour of the shoulder is lost in cases of the anterior dislocation. Now, so I'll write down all the points. Now, so in anterior dislocation, in cases of the anterior dislocation, the first point is it is the most common type. And if I ask you in anterior dislocation, what is the most common type? So you know that in scapula there is a coracoid process. So it is subcoracoid. This question has not been asked, but it can be asked. So anterior shoulder dislocation is the most common dislocation, and it is subcoracoid, that is below the coracoid. Of the coracoid is the projection of the scapula. Second, I have told you presentation. What is the presenter in form of Amitabh Bachchan? That is abduction and external rotation. How will you reduce? Reduce you by the team, and remember Kocher's method. Kocher method. So Kocher method means T for you will apply traction, E for external rotation, A for you will do adduction, and M for medial rotation. Most common nerve injured, I have told you it is the axillary nerve, that is C5, C6, and 4. I have told you this supplies the deltoid and teres minor. I am writing same thing after and after just so that you remember it. And it also present with the regimental badge sign. Fifth, in presentation, very important point, contour is lost. Contour is lost. Contour is lost. This contour loss helps you to differentiate anterior dislocation from the posterior dislocation of the shoulder, because in posterior dislocation, contour is present. Sixth point, there are three important tests. Right now, I'm just writing the name of the test. I will explain then after some time. DUGAS, Dugas test. Then Callaway test. And then third test is Hamilton ruler test. D for Dugas, D for Dusra, that means the contralateral shoulder. If there is anterior dislocation of your right shoulder, ask the person to put his hand to the next shoulder. The patient will not be able to do this. So this is known as Dugas test. What is Callaway test? Callaway sees, you remember circumference. When you will measure the circumference of the axilla, so axilla circumference will be increased because there is subcoracoid head of the humerus. And third is Hamilton ruler test. Normally there is a contour in the deltoid. So what happens if you put a scale? The scale cannot touch at the same time. The scale cannot touch the acromion process and the lateral epicondyle. But in case of anterior dislocation, this contour is lost. The scale can touch the lateral epicondyle and the acromioclavicular at the same time. So this is known as the Hamilton ruler test. So these are the three tests which I have already explained. Okay. So now, please remember, now if you remember the anterior dislocation, just reverse. There is a posterior dislocation. In posterior dislocation, it is very less. When you have to suspect posterior dislocation only in two cases, when they have given you the history of seizures, or they have given you the history of electric shock. In these cases, we have posterior dislocation, and very important thing, the contour is present. Okay, the patient will present in case of just opposite. Here it is abduction, external rotation. There it will be adduction and internal rotation, and the reduction will be just opposite. So now this 35-year-old history of trauma to the ER arms, which dissociation, which dislocation it is. So please remember abduction and external rotation, just like this. I have just explained. It is anterior dislocation. So it is anterior. So we have anterior dislocation, and it is subcoracoid. So B is the answer. And I have explained all other things. Screen को क्या हुआ? Just a minute, भाई. Just a minute. I have to cast the screen again. Just give me 2 minutes. Okay, it's being done. Window capture. I have to put just I know it's taking time. Okay, so start now. So this was done anterior dislocation. That was some glitch in the, you know. So I've told you anterior dislocation. It is uh, most common type with subcoracoid. Most common subtype. Most common nerve involved is the axillary nerve. And presentation is like Amitabh Bachchan, that is abduction, internal rotation. Treatment is team, that is Kocher method. Traction, external rotation, adduction, and medial rotation. Contour is loss. This is the way you will differentiate it with the test are Dugas test, Callaway test, and Hamilton ruler. Posterior shoulder dislocation, I have told you there will be history of the seizures and history of the electrical shock. Less common than the anterior dislocation I have told you. Now, X-ray, yes, this is very important point. This I forget. That in cases of the posterior dislocation, what happened that the glenoid, the head of the humerus will rotate like this. So what happened? It will appear like a electric bulb sign or lighthouse sign. So this can be asked that electric bulb sign or lighthouse sign, these both are seen in cases of the posterior dislocation of uh, shoulder. Okay, so this is seen in case of the posterior dislocation of the shoulder. Now, this is a very good question. Just see it. Now, see this. What kind of fracture this is? First, see this. First, try to identify this fracture. Now, the bone which is long, this is the radius bone, which is has more width. This bone is the ulna bone. So, there is a fracture of the ulna, proximal ulna fracture. Okay, so whenever we say that is proximal ulna fracture, but you are also seeing that this radius head is also dislocated. So this is a classical Monteggia fracture. M for Monteggia, M for medial. So whenever there is medial bone, that is ulna proximal part is fractured along with the radial head dislocation. That is known as a classical Monteggia fracture. And just opposite, if there is a distal radius shaft fracture with dislocation of the radio-ulnar with radio-ulnar joint dislocation, that is known as Galeazzi. Okay, so you can also, so this is Monteggia fracture. Galeazzi you can also remember by the mnemonic frog. That is fracture radius lead to the Galeazzi. So you can remember that is M for medial, so Monteggia fracture, that is medial bone, ulnar is fractured proximal part along with the radius head dislocation. And in cases of the Galeazzi, there is a fracture of the radius along with the radio-ulnar dislocation. Now, the most important point that first you have to identify this axis. Second thing you have to identify in fracture Monteggia, which is the most common nerve which is involved. Can anybody tell me which is the most common nerve involved in the fracture Monteggia? This was a question asked around 6 to 7 years in AIMS back. So in Monteggia, most common nerve injured is posterior interosseous nerve. Please remember, it is a posterior interosseous nerve which is most commonly, and it is a branch of radial nerve. Okay, so posterior interosseous nerve is the most common nerve which is gone in fracture Monteggia, and it is a branch of the radial nerve. And posterior interosseous nerve is completely a motor nerve. It does not have sensory input. So what will happen? Patient will have a symptoms like a finger drop and thumb drop. Patient will not be finger drop and the thumb drop. Patient will not able to extend the fingers and the thumbs. So there will be no sensory problem. So first you have to identify Monteggia fracture. They can give you Monteggia fracture. They can give you Galeazzi fracture. In Monteggia fracture, most common nerve is posterior interosseous nerve. They can ask kiski branch hai, that is radial nerve. What are the symptoms that is shown? Okay, the symptom is that patient will not able to extend the fingers and the wrist with no sensory problem. Now, so you see 35 years patient in the emergency after fall following X-ray, which of the following is most accurately described? So you know that this is a fracture Monteggia. Loss of sensation in the dorsal. No sensation cannot be lost because we know it is the PIM. Inability to extend thumb and finger against resistance with normal sensation. Yes, this is the answer. So this is the question, 3-step question. Okay, so there is inability to extend thumb and the finger and with normal sensation. Okay. Third point say loss of sensation. No. Fourth say weakness of the forearm and loss of sensation. No. So answer will be B. So this is the fracture Monteggia, that is proximal ulnar fracture with radial head dislocation. This is, I have told you, most common nerve is that is posterior interosseous nerve and only motor nerve. So difficulty in extension of thumbs and fingers. Sensation is preserved. Sensation is preserved. Okay. Now, can anybody tell me what is the most common nerve involved in supracondylar fracture. Most common nerve involved in supracondylar fracture. Most common nerve involved in supracondylar fracture. So please remember, most common nerve involved in supracondylar fracture is AIN, that is anterior interosseous nerve. And anterior interosseous nerve travels anteriorly and then is supplied to the two muscles, flexor pollicis longus and flexor dystoria profundus. So whenever there is an injury to anterior interosseous nerve, patient is not, and these two muscles are needed for making an OK sign like this. But when this flexor pollicis longus and flexor dystoria profundus is lost, patient is not able to make the OK sign. So please remember, OK sign loss is related to the anterior interosseous nerve, which is the most common nerve involved in the supracondylar fracture. So now you can ask that in supracondylar fracture, the fracture is above the elbow and the nerve is here. So how can supracondylar fracture can damage the anterior interosseous nerve? So the reason, the theory behind it is not a direct injury. In supracondylar fracture, because of the edema and the compartment syndrome, the anterior interosseous nerve is damaged. So it is an indirect damage to the anterior interosseous nerve. Now, which is the most common nerve involved in the given fracture? Now, can you identify this fracture? This is the radius bone. What is the most common nerve involved in the given fracture? This is the radius bone. And this is ulna. So I have just told you this is which fracture? Fracture Gallagher. Okay. So this is a fracture Gallagher, and which is so there is radius distal fracture with radio-ulnar dislocation. So you have to know, you have to identify. And what is the most common nerve involved in the fracture Gallagher? Can you tell me? In Montagia, you have the posterior interosseous nerve. Supracondylar, you have anterior interosseous nerve. In Gallagher fracture, please remember, generally it is nerve entrapment doesn't take place. Nerves are generally spared. Okay. So if they ask you which is the fracture which is least associated with nerve injury, answer will be Gallagher. Now, in upper limb, a lot of time they ask you question related to the fracture and associated nerves. Okay, so I'll tell you step by step. First, I have told you supracondylar fracture, which is the nerve that is involved, that is anterior interosseous nerve. Anterior interosseous nerve is a branch of median nerve. And which sign is lost? OK sign is lost. Why? Because this supplied two muscle, flexor digitorum profundus and flexor pollicis longus. Okay, so this question can be asked. So supracondylar fracture. Then lateral condyle fracture. Then medial lateral epicondyle fracture. Medial epicondyle fracture. Please remember, in lateral epicondyle fracture, what happens is that the lateral epicondyle is generally pulled by the extensor muscle. So if you this has a very high chances of going into the non-union. Okay. So what happened? This can develop into cubitus outside, that is valgus deformity. Therefore, after some time, it can present with the ulnar nerve, because ulnar nerve is present here below the ulna. That is the funny bone. So it can lead to the ulnar nerve palsy. But since this palsy occurs after certain time, that is known as tardy ulnar nerve palsy. So this question has been asked, that tardy ulnar nerve palsy is seen with which fracture, that is lateral epicondyle, and medial epicondyle nerve will also produce ulnar nerve palsy, but it will be from direct compression. It will not be after some time. Then I have told you Montagia fracture. Montagia is associated with posterior interosseous nerve. This is a branch of radial nerve, and the patient will have problem in extension of the fingers and the thumbs. Then I have told you supra. Then I have told you in cases of anterior dislocation of shoulder, the nerve involved is the axillary nerve. Then in cases of fracture of shaft of humerus, it is the radial nerve. If they say spiral groove fracture, then it is also radial nerve. If they ask you which is the most common nerve involved in the fracture shaft, upper shaft of humerus. So if they ask you fracture upper shaft of humerus, then your answer will be again axillary nerve. If they ask you lunate dislocation or fracture scaphoid fracture, the most common complication is just like lateral epicondyle, non-union. The nerve which is involved is median nerve. In Guy's canal, ulnar nerve. Ulnar nerve is a musician nerve. In pronator syndrome, these all are the questions. Answer is ulnar nerve. This has been asked. In painful impingement syndrome, which is the muscle involved, I've already told you it is the partial tear or the calcification or the tendinitis of the supraspinatus. Okay, so these are the fracture associated nerve. Now, in cases of posterior dislocation, in cases of congenital dislocation of hip or posterior dislocation of hip, sciatic nerve. Most common nerve is the sciatic nerve. You have to remember. In tarsal tunnel, the most common nerve involved is the tibial nerve. In fracture of proximal fibula, this is a very cliche type of question that is asked a lot of time. Proximal fibula, it is common peroneal nerve. Common peroneal nerve. So I have told all these have the questions asked or will be asked. So just revise that. In supracondylar fracture, it is the anterior interosseous nerve. In Montagia, I have told you posterior interosseous nerve, which is a branch of radial nerve. In lateral epicondyle, we have a tardy ulnar nerve palsy. In medial epicondyle, we have ulnar nerve. In pronator syndrome, it is the ulnar nerve. In carpal tunnel, it is the medial nerve, that is lunate dislocation scaphoid. In spinal groove, radial nerve or shaft of humerus, all radial nerve. Guy's canal, ulnar nerve. Shoulder dislocation, axillary nerve. I have told you. Now lower limb, I have told you posterior hip dislocation, sciatic nerve. Proximal fibula, common peroneal nerve. Tarsal tunnel, tibial nerve. Yes, this I forgot. Morton's metatarsalgia, digital nerve. This was a question which was asked in UP PGME around 25 years ago. So it is Morton's metatarsalgia, which is the nerve involved. It is the digital nerve which is involved. Now, nerve structure and injury classification. Sometimes question is also asked in nerve structure and injury classification. For example, now just understand this. If this is a big nerve, this nerve is covered by epineurium, and there are certain fascicles inside it. These are the fascicles. and fascicles are surrounded by the perineurium. And these fascicles consist of layers of axon. And these axons are covered by endoneurium. So this is, so we have a big muscle which is covered by the epineurium. Then there are fascicles inside it which consist of the axon single fibers, and these fascicles are covered by the perineurium, and then their axons is covered by the endoneurium. Now, if we see the Sudan classification of nerve injury, of nerve injury. So what we see, he divides the nerves injury into three types. It is NAM. First is neuropraxia. Second is exontemesis, and third is neurotemesis. Okay, now we'll see. We know there is myelin sheath. MS is for myelin sheath. A is for axon. Then from inside will go endoneurium. Then we have P is for perineurium, that is covers the fascicles, and endoneurium which covers the single axon, and perineurium which covers the fascicle, and then we have epineurium, that which covers the complete nerves. Okay. So in neuropraxia, what will happen? There is problem in the myelin sheath, but axon is perfectly fine. Endoneurium, perineurium, and epineurium is fine. So this is a normal injury, and this is reversible. For example, if we sit for long duration, we feel paresthesia or loss of sensation or anesthetized area. That is a neuropraxia because myelin sheath conduction is lost, but axon is normal. So they reverse back. In exontemesis, myelin sheath is injured. There is also injury to the axon, but endoneurium, perineurium, and epineurium are intact. This is the first type of exontemesis. Second exontemesis, that is higher grade of exontemesis, that is myelin sheath. There is problem. There is problem in axon, and there is also problem in endoneurium, but perineurium and epineurium are normal. Then further, when the injury grades increases, there's problem in myelin sheath, problem in axon, problem in endoneurium, problem in perineurium, but epineurium is normal. In cases of neurotemesis, epineurium is also involved. So there is involvement of everything, myelin sheath and axon, epineurium, endoneurium, and perineurium. Now, the same Sudan's classification have been divided by the Sunderland into five types. Sunderland. Type 1 is nothing but the neuropraxia. Type 2 is the first exontemesis, where axon is involved, but all the neurium, that is endo, peri, and epi, is normal. Type 3 is this one, where endoneurium is also involved. Type 4 is this one, where perineurium is also involved. And the fifth is neurotemesis. So question can be asked, Sunderland classification, fifth is nothing but neurotemesis. Okay, so a lot of question can be asked on this. If you understand this, you can easily, sorry, so this is all in neurotemesis, all the structure, that is myelin sheath, axon, then we have endoneurium, perineurium, epineurium, all will be involved. Okay. So a lot of questions can be asked on it. Even in physio, they ask question on it. Okay. So what is this? Can anybody tell me what is this? Okay, this is cock-up splint. This is cock-up splint. Used in which nerve injury? This is used in radial nerve injury. There is, you see, this is a frame. Now you can release it or you can tighten it. So this is actually dynamic cock-up splint. So in NICT, this has been asked. The dynamic cock-up splint used in radial nerve injury. Radial nerve is gone in which fractures? In fracture shaft of humerus and spiral groove fracture. And also posterior interosseous nerve is gone in case of which fracture? Montegio. So name the splint and which nerve involved. So it is cock-up, dynamic cock-up splint used in radial nerve. So it is dynamic cock-up splint used in the radial nerve. Now what is name the splint and what is used for? Now this is also a cock-up splint. It is also a cock-up splint, but this is not dynamic. You cannot release it or contract it. So this is a normal cock-up splint. It is also used for the radial nerve. Okay. So this static cock-up splint used for the radial nerve injury. Now this, I have told you what happened in claw hand. Claw hand is caused because we'll study ulnar nerve, medial nerve, every nerve. So what is this? Name the splint and use for what injury? So here what happened in claw hand, there is what happened, there is hyper extension of the, this is your metacarpus and this is your interphalangeal. So there is hyper extension of metacarpophalangeal joints and flexion of interphalangeal joints. So we have to use a splint which does just opposite to this. So what it does like this. That is, it does flexion of the metacarpophalangeal joint and extension of interphalangeal joint. So this is known as which splint? Can anybody tell me? So this is used for claw hand, used for ulnar. This is knuckle bending splint. This is the knuckle bending splint. Used for claw hand, used for ulnar palsy. What happened in ulnar palsy? Hyper extension of metacarpophalangeal joints and flexion of interphalangeal joint. Was what this splint does? It does flexion of metacarpophalangeal joint and extension of interphalangeal joint. This can be asked. Knuckle used for claw hand. Claw hand, there is hyperextension of metacarpophalangeal joint and flexion of DIP and PIP. Now, what is the name the splint and for what purpose it is used? This is the Thomas splint. Thomas splint, and it is used for fracture of shaft femur. So this is a Thomas splint which is used for fracture shaft femur. Now they will not ask that question. Thomas splint used for fracture shaft of femur. Now, can anybody answer the name the splint and for what purpose it is used for? Yes, this is a Milwaukee, Milwaukee, Milwaukee splint, and it is used for scoliosis. Very important. There is another splint whose name is Reisers, REISS. We'll study it in after some time when we'll see scoliosis. There is that is known as Reisers splint used for scoliosis. So this is Milwaukee splint which is used for the scoliosis. So it is Milwaukee splint used. Now, yes, this splint. This has been asked in the aims. Name the splint and for what purpose it is used. I can tell you this is splint. This is used for the genu valgum or genu varus deformity. You have to name the splint. I will give you a hint. It is somewhere related to the fishes. एक मिनट दे रहा हूँ. Just a minute. Sorry for interruption. This is a I'm this is mermaid splint. Mermaid splint, and this is used for genu valgus or varus deformity. This has been asked in INICT. Okay, so this is a mermaid splint. Please remember this. Mermaid splint used for genu valgum and genu varus. Now name the test and for what purpose it is used. This is a Durkan's test. Durkan test used for median nerve. So if there is a patient of hypothyroidism or case patient of trauma or a patient of fracture of scaphoid or dislocation of lunate, these packs can develop carpal tunnel syndrome. So whenever there are these 5 points you have to remember. If there is patient of trauma on the wrist, patient of hypothyroidism, patient of scaphoid fracture or patient of lunate dislocation present with pain in the wrist, you will think, or obese patient, you will think of carpal tunnel syndrome. And there are 3 tests which you have to know. First is that this test, that is Durkan test, where you will apply pressure on this area, so patient will feel pain on the palm area. So this is known as the Durkan test or the Durkan test, Durk, Durkan test. Second is test that is known as Tinel test, Tinnel, Tinel test. What happened in this? You will slightly extend the wrist and you will tap on this carpal tunnel area, and the patient will feel a vibratory sensation. That is normal. Everyone will feel. But if the patient feels pain, then this test is positive. Even you will feel the vibration. So that is a Tinel test. So Durkan test, Tinel test, and the third is the Fallon test. Fa- Fallon test. What happened? You will ask the patient to like this. And if within 1 minute patient develops extreme pain or some can develop pain within 30 seconds, that is known as Fallon test. Positive. It is also for median nerve, carpal tunnel. So you have to remember 3 tests for carpal tunnel syndrome or median nerve. That is Durkan test, the Tinel test, and the Fallon test. So this is Durkan test, and please remember Durkan. If they ask which is the most sensitive, Durkan test. Medial nerve. Other tests are Tinel test, I have told you, and the Fallon test, I have also already told you. Now this is the test. Name the test and for what purpose I have used. Now please remember, this is the question. A lot of time they ask you. This is the test we do for you. We do for D. Curvain, Tino, synovitis. And the name of this test is ECOF test. EICHOFF. ECOF test. What is the muscle involved in Dill Curvain? Tenosynovitis? It is the abductor. Abductor pollicis longus and extensor pollicis brevis. Please remember. Okay. Now, if I ask you, abductor pollicis longus is supplied by which nerve? Okay, we'll come to that in the nerve injury. So, ECOF test, which is this is the ECOF test done in case of D. curvain tenosynovitis, which involves 2 muscle abductor pollicis longus and extensor pollicis brevis. Okay. So what happened in this test? What you will say, you will ask the patient to first what you will ask the patient. Uh, you will ask the patient to first put his thumb like this and put his fist like this, and then you will do the what? You will ask the patient to put his wrist like this. If he or she feels a lot of pain in this area, that means this ECOF test is positive. That means this ECOF test is positive. And please remember, don't confuse. This is not Finkelstein test. What is Finkelstein test? You have to slightly extend the wrist and you have to pull the thumb. If there is a pain in this area, that is Finkelstein test. Okay, Finkelstein test. So this is ECOF test. In ECOF test, you'll ask the patient to pull his thumb like this and then do like this. And if he feels a lot of pain here, that means he is suffering from decurvent Okay. And in Finkelstein test, you simply pull the thumbs. So ECOF test, this is ECOF test used in decurvent decurvent The two muscles involved is abductor pollicis longus and extensor pollicis brevis. Okay, so APL is supplied by the radial nerve. Abductor pollicis longus is supplied by the radial nerve. Abductor pollicis brevis is supplied by the medial nerve. That we will see after some time. Okay. Full. And when we will see Bennett and Ronaldo fracture, then we will see these points. Okay. Now, what is this test that is shown? Lot I can give you a hint that this test is done in cases of lateral epicondylitis or tennis elbow. In lateral epicondylitis or tennis elbow, which happens in the patient people who plays the tennis a lot, what happens? You slightly flex the patient, you stabilize the elbow, and you ask to extend the wrist, and you put a pressure on the downward direction, and you ask the patient to extend the wrist. So if the patient feels pain in lateral epicondyle region, this test is called as positive. And what is this test? This is known as COZEN. That is the Cozen test. Cozen test. Cozen test for lateral epicondylitis or tennis elbow, where you flex the patient. You flex the elbow and you ask the patient to extend the wrist, and you put a reverse force in the reverse direction. If there is a pain in this area, that is a positive test. This is a Cozen test. This has been asked several times. So please remember. So this is Cozen test for tennis elbow or lateral epicondylitis. Okay. Now this test, name the test and it is used for, very important. I can tell you this is used for supraspinatus muscle. So this test is used for supraspinatus muscle. So what happened? How you will test? You will ask the patient to put his arms like this, and then you will ask to do internal rotation and put his thumb towards down, and you will ask the patient to uh, raise the shoulder. If the person start feeling pain in raising the shoulder, that means this test is positive. What is the name of the test? That is, yes, empty can sign, empty can test. So this patient, and in the second part, you can also ask the patient to resist downward pressure applied by the examiner. So this is empty can test, empty can sign, which is seen in supraspinatus muscle in injury. So empty can test supraspinatus muscle. Now there are different tests for upper and lower limb. Okay. So we have to see this topic in great detail. First, we'll see ulnar nerve. Ulnar. So I've seen a very good mnemonic on the internet. You can remember ulnar nerve by A, B, C, D, E, and F. Okay. A say you can write ulnar like this. B say you can write book test. C say you can write card test. D say you can write dorsal interossei. I will explain everything. E say you can write Igawa test. And F say you will write Froment sign. Now please remember, we have been studying from time immemorial that there are a mnemonic by PAD and DAR. P is for palmar interossei and D is for dorsal interossei. Palmar interossei help in the adduction and dorsal interossei helps in the abduction. And whether it is palmar interossei or dorsal interossei, they are supplied by the ulnar nerve. So ulnar nerve supplied partial interossei and dorsal interossei. Palmar interossei helps in the adduction and dorsal interossei helps in the abduction. Okay, so once we know all these things, we can do all the question of ulnar. So what is book test? In book test, what we will do, we'll ask the patient to hold a book and the patient will hold the book. Patient will hold the book like this. That is between the, okay, I'll increase the, so patient will hold the book like this. That is between the thumb and the between the index finger. So he will be requiring which muscle? That is adductor pollicis. Adductor pollicis. So basically, book test is done. Book test is done. So basically, book test is done for the adductor pollicis muscle or indirectly for ulnar nerve. So they can ask you this question that book test is does for which muscle, adductor pollicis for which nerve, and they can also ask you question that adductor pollicis is supplied by which nerve. Answer will be ulnar nerve. So when the patient will not be able to uh, uh, hold the book like this, he will hold the book in this form, that is in the form of like this. Okay, by abduction at the thumb and abduction and the by flexion at the thumb and flexion of the index finger like this. Okay, so then this test will be known as book test. Now D and E club them together. That is for dorsal interossei we have Igawa test. We know that dorsal interossei, what does they do? They helps in the abduction. So when we, what is Igawa test? We'll put for example, if this is the floor, we will ask the patient to put his finger like this and try to move the middle finger and the uh, this ring finger away. If the patient is able to move them, that means his dorsal interossei are working normally. Igawa test is negative. If there will be problem in dorsal interossei, then abduction, that is separation of middle finger and the ring finger, will not happen, and then we'll say that Igawa test is positive. So Igawa test is basically done. You can be asked in two. It is done for ulnar nerve. There is no problem, but ulnar nerve especially for dorsal interossei. Similarly, card test. Card test is done for ulnar, basically palmar interossei. Palmar interossei. Okay. So palmar interossei, what you will do? You will ask the patient to put between the middle finger and the ring finger. You will ask the patient to put some card here, some card, and you will try to snatch it away. If adduction, if the palmar interossei muscle will be normal, you will not be able to snatch the card. That means adduction will be normal. And but if with a small force you can take the card away, that means card test is positive. There is defect in the palmar interossei. So card test and Igawa test can be asked in two ways. First, which muscle? So Igawa test is for the dorsal interossei, card test is for the palmar interossei, or can be asked simply a superficial question for which nerve, that is ulnar nerve. Now, if book test is positive, that is known as Fromet sign. If the patient is not able to hold the book with the help of adductor pollicis muscle and he holds the book like this, then that is known as a Fromet sign. Okay, so this is the test for the ulnar nerve. If you remember this, you can solve every question related to the ulnar nerve. Now, coming to the median nerve. Median nerve, you just remember the term P. Okay, so we can have pencil test or pen test. Then we can have pointing test. Okay, so what is pencil test? If this is my hand, I will keep the pen slightly above the range of thumb, and I will ask the patient to abduct the thumb and touch. For example, I am able to touch this pen, and the muscle which is involved is abductor pollicis. which is the muscle that is abductor pollicis. Which abductor pollicis longus or brevis? It is abductor pollicis brevis. Remember, abductor pollicis longus was involved in decurvent tenosynovitis along with extensor pollicis brevis. And here, and abductor pollicis longus, that is nerve is supplied by the radial nerve. Remember, whenever the muscle comes abductor pollicis longus, you have to remember 3-4 points. First, abductor pollicis longus along with the extensor pollicis brevis, inflammation is known as decurvent tenosynovitis. Abductor pollicis longus is the muscle which is supplied by radial nerve. And third, there are two fractures. One is the Bennett fracture and other is Ronaldo fracture, which is the fracture of basically the first metacarpal. Okay. So in the fracture of first meta, that we'll see after some time, in the fracture of the first metacarpal base fracture, if there is a single fragment, it is known as Bennett fracture. If there are two or more fragments, it is known as the Ronaldo fracture. So the metacarpal is pulled by which muscle? It is abductor pollicis longus. So we have three: abductor pollicis longus along with extensor pollicis brevis involved in decurvent tenosynovitis. Abductor pollicis longus supplied by the radial nerve, and abductor pollicis longus pulls the fracture segment in cases of Bennett fracture and Rolando fracture. Now, so I was telling you pencil test or pen test. If I put the pen like this and I will ask the person to abduct the thumb and touch it, he will not able to. If he is not able, that means there is problem in which muscle? Abductor pollicis brevis, or and the nerve is median nerve. So this can again be asked in two ways. Either the patient has a abductor pollicis brevis is applied by the median nerve, or pen test किस मसल्स के लिए होता है, विच मसल के लिए? एब्डक्टर पल्सिस ब्रेविस. ओके, इन दिस स्टेट. देन pointing test. If you will ask the patient to flex his fingers and make a fist, he is not able to flex this index finger. Index finger, because his flexor distorium profundus. It is supplied by which muscle? Flexor distorium profundus. It is supplied by the anterior interosseous nerve, which is a branch of median nerve. So flexor, there is a problem in flexor distorium profundus because of problem in anterior interosseous nerve, which I have told you is most common nerve injured in fracture supracondylar. So this will be pointing test. Okay, so if they ask you in pointing test is done for which nerve, it is median nerve. Then third nerve is radial nerve. Radial nerve, it is everything is dropped. If posterior interosseous nerve is involved, you will have no sensory abnormality, and what happen? Patient will find difficulty in extension of fingers and the thumbs. If there is a high radial nerve injury, then there will be a wrist drop. Okay, so it is very easy. So now, so this was regarding the different test. Other test I have already just write in carpal tunnel syndrome. I have Durkan test, Tinel test, and one more, that is Fallon test. In decurvent tenosynovitis, we have two tests, that is Ecoff test and other is a Finkelstein test that I have explained you. Then I have explained you in Monteggia fracture, which is the most common nerve involved? Posterior interosseous nerve, which is a branch of radial nerve. So there will be a problem in extension. In supracondylar fracture, which is the most common nerve involved, that is the anterior interosseous nerve. That is OK sign will be absent. In supraspinatus muscle, which was the test? That is the empty can test. In subscapularis, That was the lift off test. In anterior dislocation, there was Dugas test, there was Hamilton-Zuller test, and Callaway test that we have already seen. Now, and then in cases of ankylosing spondylitis, there are three tests: modified Schaubner test, basically two tests: modified Schaubner test and Gailslein test. Gailslein, Gailslein test. These are the two tests which have been asked in Neet PG as well as INICT. I will explain this after some time. Okay, so modified Schaubner's test and Gailslein test. Then there is a, for lower limb, you have to remember a Thomas test. Thomas test is done for fixed flexion deformity of the hip. What do you do? I will also show you a diagram. Then there is a Thompson test. What happened in Thompson test? Patient is in this supine position. Okay, and then you flex his knee and you put force or you apply force on the calf muscle. So there is what? There is a plantar flexion of the foot. If that is loss, that is known as Thompson test. So Thompson test, T for Thompson, T is for tendinoachilles. Okay, so it is done for tendinoachilles. Please remember, can anybody tell me what is the, there is a Thomas splint, then Thomas test, then Thompson test, and then there is Terry Thomas sign. These are the four names, just like so. Thomas splint is for femur fracture. Thomas test, we have just seen, it is for fixed flexion deformity of the hip. Thompson test is for tendinoachilles. And Terry Thomas sign, you have two bones. One is scaphoid and other is lunate. If there is a dissociation of scaphoid and lunate, then the sign which is seen on X-ray, that is known as Terry Thomas sign. This has been asked in the Neet PG. Okay. So in lower limb, just remember Thomas test for fixed flexion deformity, Thompson test for tendinoachilles, and for congenital dislocation of hip, you have to remember two tests. One is Barlow test and other is Ortolani test. Barlow is like Marlow in Hindi we say na Marlow. So what you do, you actually dislocate the hip, and in Ortolani you relocate the hip. So in congenital dislocation of hip, what happens? The glenoid cavity is very shallow, so it's very easy for dislocate hip joint to dislocate. So what you do in Barlow, please remember Barlow, say bad. So what you do, you adduct the child and put a push force. So what happened? There is dislocation of the hip joint, and then when you do the opposite, that you abduct the hip joint and you pull, then there is relocation. So in Barlow, what you do, you adduct and push, and in Ortolani, you abduct and pull. So this is what the congenital hip location. They have been asked a lot of time. So these all are the tests. So I've told you ulnar nerve, also known as musician nerve, A for ulnar nerve, B for book test. The muscle involved is the adductor pollicis. If book test is positive, that is known as Fromet sign. Then I've told you the card test for palmar introsi, difficulty in adduction of finger, cannot hold card between middle and the ring finger. Then for Igawa test for dorsal interossei, put hands on the floor and cannot move middle finger away from the index finger. And then Froment sign, I've told you if the book test is positive, that is known as the Froment sign. I have median nerve, I've told you the pen test, I've explained you the pinch graph test. Okay, I forget to pinch graph test. I have told you in anterior interosseous nerve is most common nerve involved in the supracondylar fracture. So when there is supracondylar fracture, there is a posterior interosseous nerve, so anterior interosseous nerve involved, and it supplies to two muscles, that is flexor pollicis longus and flexor dystorum profundus. So what happened is that when I asked the patient to make an OK sign, he used flexor pollicis longus for flexing the thumb, and index finger flexing, he used flexor dystorum profundus. So the supply to these are lost, so patient is not able to make an OK sign. This is known as pinch grasp test. Okay. So this I have already explained. This I have told you that abductor pollicis brevis. This is supplied by the median nerve. Abductor pollicis longus. Indi curvain is supplied by the radial nerve. Drop, wrist drop, finger drop. Posterior intrusion is gone in Montagia fracture. Problem in extension of finger and the thumb. This I have already explained. Decurvent tenosynovitis, APL, EPP, I have told you. Ecoff test and Finkelstein test, I have told you. Anterior shoulder dislocation, Dugas test, Calvé test, and then Hamilton ruler test, I have explained. Subscapularis lift off test. Then in tennis elbow, we have Posen test. In supracapular fracture, we have anterior interosseous nerve. Then we have OK sign. Supraspinatus, we have empty can test, already explained. These all are the question. Then radial groove, we have shaft, humor, radius nerve involved. Medial epicondyle, we have fracture ulnar nerve. Lateral epicondyle, we have fracture tardial nerve. Carpal tunnel syndrome, we have Durkan test, Fallon test, and Tinel test. So all these have been, and in Montagia fracture, we have posterior interosseous nerve. This has been explained. Spine scoliosis, Adams test. What is Adams test? Adams test is basically used to differentiate between pathological and physiological scoliosis. If you if you will ask the patient to bend forward, so physiological scoliosis will be gone, but pathological scoliosis will be present. So that is known as the Adams test. So Adams test is done for the scoliosis. And ankylosing spondylitis, I have told you, modified Schobner test, Geinslin test, and pump hand test. These tests you have to remember by heart. Now, what is modified Schobner's test? What you will do, you will go behind the patient, you will uh, you will come to the L4, L5 joint, or if there is a venous dimple is present behind, you will mark that area, and you will take another area 10 centimeter above it and 5 centimeter below it. So the distance between those two areas will be 15 centimeters. You will ask the patient to bend forward, and when the patient will bend forward maximally, what the distance between them should not decrease. But if the distance between them decreases, then that is known as the modified Schobner's. That is modified Schobner test positive, and that is the ankylosing spondylitis is positive. You have to remember this. Okay. चल रहा है भाई. Now, lower limb test, I have told you Thomas test, that is flexion deformity of the hip. I'll show you this with the help of a diagram. Then Thompson test for tendinoachilles, meniscus, you have a McMurray test and Aplis test. And for cruciate ligament, you have Draw's test. And for CDH, I have explained you Barlow test and Ortolani test to dislocate the hip, and that is adduction and push test to relocate the hip, abduction and the pull. Now, let me explain you what is the Thomas test. Thomas test is basically the flexion deformity of the hip. So, what you do, you put the patient on a table, and for example, and you will ask, for example, if you are testing the patient, you will ask the patient to lie down on the table with both the limbs touching the ground. You will ask, for example, to flex the right lower limb completely at the hip joint. So he will completely flex at the hip joint. And if the left lower limb uh, comes does not touch the ground, comes off the ground, or if there is a lateral rotation in the lower limb, that means this patient has a fixed flexion deformity of the. But please know, if obese patient can have these false positive. So, this Thomas test can be false positive in the obese patient. I will show you with the help of a diagram. Okay, let me show you. Um, uh, Thomas test. THO Thomas test. Okay, so like this, it will be like this. So Thomas, if you will ask the patient to lie, you will ask the patient to lie down on the table, and this is the complete flexion is being done. So this, the opposite limb should touch the ground. If it comes out of the ground or there is a lateral rotation, then we will say that this test is positive. So, and but please remember, in obese patient it can be false positive. So this is known as the Thomas test, which is done for the fixed flexion deformity. Okay. OCDH, everything. And meniscus, please remember M for meniscus, M for McMurray's, and Epley's test. You can remember Apple because you have to solve MCQ. Okay. Now, this is a very important question. A 10-year history of fall, and there is supracondylar fracture with the development of gun stop deformity absent OK sign. If there is a patient of supracondylar fracture and there is an absent OK sign, that means which nerve is involved? That means it is involvement of anterior interosseous nerve, which is a branch of median nerve. Now, what happened in supracondylar fracture? The what happened? The most common, it is a metaphyseal fracture. It is a metaphyseal fracture. Just like lateral epicondyle, the most common complication is non-union. In supracondylar fracture, it is a metaphyseal fracture. So it will unite, but most common complication is a malunion. So supracondylar malunion. So what happened? The person can have a injury like this because hand will go in cubitus varus, VARUS, inward. So this is known as gun stop deformity. This is gun stop deformity. So after supracondylar fracture, your hand can be like this because it is a metaphyseal fracture. So most common complication is malunion. Most common complication of lateral epicondyle fracture is non-union. In scaphoid, it is non-union. But here the most common complication is gun stop deformity or it is cubitus varus. So it is why? Because of the malunion. So gun stop deformity in supracondylar fracture is because it is a metaphyseal fracture and leading to malunion. So now, for most accurate statement we have to see. Gun stop deformity is due to the distal humerus fracture and it indicates injury to the radial nerve. No, it is the injury to the anterior interosseous nerve, which is the median nerve. Absence of OK sign is suggestive to of ulnar nerve. No, we have just read gun stop deformity caused by malunion of supracondylar fracture, which injury to the anterior. This is the best answer. Okay, this was a question which was asked in USMLE. There is development of cubitus valgus. No, it lead to the cubitus varus. So in supracondylar fracture, you have to remember two complications. First, it is a metaphyseal fracture, so lead to malunion, which can lead to the which kind of deformity? Gun stop deformity. That is cubitus varus. Second, it can lead to the injury of the median nerve, that is anterior interosseous nerve, and absence of OK sign because flexor distorium profundus and flexor pulsus longus are involved. So this is very important. Now, what is fracture of necessity? There are certain fractures which you have to deal them, which you have to treat them as soon as possible. Those are known as fracture of necessity. You have to intervene. There is no other possibility. So there are total 6 fracture of necessity. So in cases of fracture of necessity, you can never do. So whenever these fractures are mentioned in the MCQ, always tick, never select conservative management. Always you have to intervene. What are these fractures? These are lateral epicondyle fracture. Lateral epicondyle fracture. Why? Because lateral epicondyle, there are extensors are attached, so they pull it. Second is femur neck fracture. Third is fracture Galeazzi, that is distal radius fracture along with the radioulnar dislocation. Fracture Monteggia fracture. Please remember it should be classical Monteggia, that is proximal ulnar fracture with the uh, radial head dislocation. Fifth, part fracture of Olecranon process of Olecranon process or patella. Okay, so why? Because if there is a patella fracture, both the patella will be pulled apart if there is a part fracture. So they will not unite. So this is not every patella fracture is fracture necessity. Part fracture of patella, part fracture of the ulna process. Okay, and then intra-articular fractures. Intra-articular fractures, example, Barton fracture of the wrist. This is intra-articular fracture of the radius, that is Barton fracture. So these are fracture of necessity. Olecranon process is also pulled by the tricep. So you have to, it is also fracture of necessity, just like lateral epicondyle. So it is a lateral epicondyle fracture because extensor muscle always pull the bone. Fracture femoral neck, Galeazzi, Monteggia classical, two-part fracture of the patella, Olecranon process, intra-articular fracture like Barton fracture. Now name this angle. This has been asked in NICT. Name this angle and what is the normal value and for what it is used. Can anybody tell? Now this is humerus. So if there is a line coming, there is a line coming from the humerus and there is a second line which is going through the capitulum or lateral epicondyle. So the angle between them, this angle, is known as BAUMAN, Bauman angle. So this Bauman angle is used in case of the elbow. What is the normal value? The normal values, there should be a less than 5 degree of change when compared from the other side. If there is a angle difference of more than 5 degree when compared from the other side, then that is pathological. This is Bauman angle. You can remember Bauman from elbow. Bow say Bauman angle. Okay. So this they have asked. So this is a Bauman angle, less than 5 degree, normal when compared from the other side. Shaft between the shaft of the humerus and a straight line drawn through capitulum or lateral epicondyle. So this has been asked. So this is a Bauman angle. Please remember this question. Okay, now these are the two questions. Name the angle and the normal values. Name this angle and the normal. So this is the foot. This is calcaneum. This is talus. So what if you see, this is, I'll tell you one important thing about mm, if this is calcaneum, so what have this is known as calcaneum tubercle. Calcaneum tubercle. This is the highest point of the calcaneum tubercle. This is posterior articular surface. Sorry, and this is anterior articular surface. So now if we draw a line from highest point on the calcaneum tubercle to the posterior articular surface like this, and other line from posterior articular surface to the anterior articular surface. So this is known as Bowles angle. And the normal values, please remember B and O. B say do 2 and O say 20. It is 20 to 40 degree. So this is Bowles angle, which is used in calcaneum fracture. So which one is, so this angle is, this angle is Bowles angle. That is, a line is drawn from the calcaneum tubercle to the posterior articular surface, and other line is drawn from the anterior articular surface to the posterior surface. Now, I have already told you this is posterior articular surface, this is anterior articular surface, and this is the slope of posterior articular surface, this is the slope. If we draw a line through anterior slope and posterior slope, the angle between them is known as Gisane angle. The angle between them is known as Gisane angle. This is the anterior articular surface slope, this is the posterior articular surface, and the angle between them is, this is known as Gisane angle. And the normal value is 120 to 140 degree. So Bowles angle, they have normal 20 to 40 and Gisane angle, and both of them are used in cases of calcaneum fracture. This I have explained. So one is Gisane angle, that is 120 to 140 degree between the anterior articular slope and posterior articular slope, used for calcaneum fracture normal value. And then second is the Bowles angle. I was saying Bowles. Okay, so this is Bowles angle, BOHLER. The normal value is 20 to 50 degree line. It is the angle between two lines. First line is a line from the highest point of calcaneum tubercle to the highest point of the posterior articular facet. I've explained you. And second is the highest point of anterior and posterior articular facet. This is the second line between them. I've explained it. Now name this angle. Can anybody explain this angle? Yes, this is the Meary's angle, Meary, Meary angle. It is the this is the talus bone, and this is the first metatarsal. So the angle between the talus and the first metatarsal is known as the Meary's angle, and the normal value is 0 degree. So this is the only angle with normal value is 0 degree. Meary's angle between the talus and the first metatarsal. And they have also named the angle and normal value of this. So this I have told you, this in between the talus and the first metatarsal, Meary's angle, normal value 0 degree. Now what is this? This is a talocalcaneal angle. Talocalcaneal angle. Talocalcaneal angle. Okay, which is used for foot varus or foot valgus. So how will you do? You will put one line from the talus to the first metatarsal and a second line from the talus to the fourth metatarsal, and this is the angle between them. First line from the talus to the first metatarsal and second line from the talus to the fourth base of the fourth metatarsal. The normal value is 25 to 40 degree. A value less than 25, what will it say? That means they are too close. So it will be known as foot varus. And if the value is more than 40 degree, that will be known as foot valgus. Okay, this is the talocalcaneal angle. So first was the Meary angle, normal value 0 degree between talus and the first metatarsal, I have explained. Second is the talocalcaneal, also known as the Kite's angle. Yes, this angle is also known as talocalcaneal angle, but it is known as the Kite's angle. Kite's angle. This is the Kite's angle. So this is a Kite's angle that normally is 25 to 40 degree. Angle between the two lines. First line drawn from talus to the bone of the first metatarsal. Second line is drawn from anterior base of the fourth metatarsal. If it is less than 25 degree, hand foot varus. If it is more than 40 degree, it is hand foot valgus. They can ask you this question. Now, true regarding fishtail deformity. This was a question which was once asked in INICT. What is fishtail deformity? It is a basically what happened. There is a, if for example, if this is your ulna, if this is your ulna is like this, ulna is like this. So anterior ulna is like this. So anterior, this is a coronoid process. Then there is a cavity, and then there is a olecron process. And these two areas, it fits on the trochlea. Okay. Olecron process goes into the olecron fossa on the humerus. So olecron fossa is in the humerus. Olecron process is in the ulna. So this is olecron process which fits into the uh, olecron fossa of the humerus, and this is coronoid process, coronoid, CORO, coronoid process. And between them, they fits in the trochlea of the, which is pulley-shaped structure present in the distal end of the humerus. Okay. So if this trochlea is not ossified, or if after ossification it is reabsorbed, that is known as fish-tail deformity. So answer is, it is characterized by this distal humerus deformity of trochlea. Okay, so it is characterized by distal humerus because trochlea is a part of distal humerus. Please remember this. Okay. So true regarding the fistula deformity, what happened in that the trochlea is either not formed, or if it is formed, so it is reabsorbed. This has been asked. What is this X-ray? This is very difficult to identify, but what we can see, there is this is radius, this is humerus, and this is ulnar. I was told this is the ulnar process. This, sorry. So this is radius, this is ulna, this is humerus, this is ulnar process, which I was explaining. This is coronoid process. And this is the cavity which gets fixed into this. On the posterior surface of the distal end of the humerus, we have olecron fossa. Okay, so what we are seeing here, just see again. There is posterior dislocation. Posterior dislocation. So first thing is there is posterior dislocation of elbow, because anterior or posterior dislocation is identified with the help of the ulna. If ulna goes back posterior, it is posterior dislocation. Also see, this is, what is this? This is coronoid process of ulna. There is a fracture. So there is coronoid fracture. And there is also fracture of the radial head. Radius head fracture. So these three things are present in this: posterior dislocation of the elbow, coronoid process fracture, and radial head fracture. This is known as terrible triad of Hutchkiss. This is the worst kind of injury that a person can go around the elbow. So terrible triad of Hutchkiss, that is posterior dislocation of the elbow, coronoid process, this is a part of ulna, and then radial head fracture. This is known as terrible triad of Hutchkiss. This can be a potential question that can be asked. Okay. Now name this fracture and what kind of deformity is present with it. Also discuss it now. Now the bigger bone, this is the radius. So this is the radius fracture. This is articular process. The fracture is extra articular. So this is extra articular fracture of the radius. And if you see the lateral X-ray, the distal portion has gone into the dorsal part. So if distal portion goes into the dorsal part here, that is, if radius fracture, if this is in radius fracture, it is extra articular fracture, and the distal part has gone towards dorsal. That means it is a Colles fracture. So this is how you have to identify Colles fracture. It is will be extra articular fracture of the radius, and the distal fragment will go dorsally. Now, if the same distal fragment will go ventrally, extra articular fracture of the radius, and the distal fragment goes towards the palm side, then that will be known as Smith fracture. So Smith fracture and Colles fracture both are extra articular fracture and both required that close reduction and immobilization. Now, in Colles fracture, what will be the deformity? We all know dinner fork deformity. Dinner fork deformity. And in Smith fracture, we have a garden spade deformity. So please remember Colles, please remember CD. Colles fracture distal segment goes dorsally. That is, it goes backside. So that will be Colles. If it goes ventrally towards the palm, that is Smith fracture. Okay. So the now this fracture. Now if you see this fracture, these are two fractures which are present in front of you. This is also radius, this is ulna, this is also fracture of radius, but it is involving the articular surface. So this is not a Colles fracture. So it is a radius fracture which is intra-articular, and this is known as Barton's fracture, which we have just studied, that is fracture of necessity. Okay. Now same here, this is radius, this is ulna, this is the styloid process of the radius. And since there is a fracture in the styloid process of the radius, that is known as Schoffer's fracture. Okay, Schoffer's. So Barton's, it is intra-articular fracture of radius. Note Colles and Smith are extra-articular, I have told you, and this is Schoffer's fracture, that is styloid process radius. So this is Schoffer's fracture, this one. Chaue, Schoffer's fracture. Please remember this. This is known as the Schoffer's fracture. Now this fracture, which bone? First you have to answer which bone fracture. Second is most common complication. Second most common complication, and there is a very important point regarding this bone. And if this bone is fractured, where you will get the tenderness. So these are, so please remember this bone like this. This is radius. This is bone is scaphoid bone. Scaphoid bone. Scaphoid bone, very important point to remember. There are certain points which you have to remember. Scaphoid bone is the most common carpal bone to get fracture is the scaphoid bone. Please remember the arterial supply to the scaphoid bone comes from distal to the proximal. So it can goes into the avascular necrosis, but most common complication is not avascular necrosis. Most common complication, if I ask you of this scaphoid fracture, is it is non-union, just like lateral epicondyle. Second most complication is avascular necrosis. Okay, and a very important point is that it takes its supply from distally to the proximal. That's why, and which fragment goes into avascular necrosis? Proximal fragment. The avascular proximal fragment goes into avascular necrosis because uh, arterial supply comes from the distal end. And the tenderness you will see in anatomical snuff box. Anatomical snuff box. So tenderness you will see in cases in the anatomy. So if you they show you, so they can show you the fracture. They can ask you about the arterial supply, about the most common complication, non-union, second most common avascular necrosis, which part goes into avascular necrosis, and where the tenderness. Everything can be asked, and it is the most common fracture in the carpal area. So answer is scaphoid is the most common. Most common complication is non-union. Second most common is avascular necrosis, proximal segment. Blood supply from distal to the proximal can also lead to the carpal. Yes, I have told you there are two bones, that is lunate dislocation and scaphoid fracture can lead to the carpal tunnel syndrome. And tenderness can be present in the anatomical snuff bones. Most common carpal bone to get fracture. This was a question that has been asked in Neet PG. Answer is scaphoid. Most common bone to dislocate in carpal. Answer will be lunate. Okay. Now explain the pathology and the signs. So this is your scaphoid. and this is your lunate. And there is a gap between them, dissociation. So this is the dissociation of scaphoid and lunate. I have already told you this is known as Terry, Terr, Terry Thomas sign. Okay, this is known as Terry Thomas sign. So this scaphoid lunate dissociation known as the Terry Thomas sign. Now name the pathology in this X-ray. So this is very difficult. So this is like a cup which is spilling. So this is known as cup spill sign seen in cases of lunate dissociation. So spilled cup sign or cup spilled sign that is seen in cases of the lunate dissociation. Now name the fact. I have told you this, and this is the first metacarpal base fracture. And since there is a single involved, that is known as Bennett fracture. This is known as Bennett fracture. If more than two fragments are involved are formed, that is known as Rolando fracture. Rolando fracture. In this is the first metacarpal. Here a muscle is attached. That is, we are reading from the starting APL, abductor pollicis longus. So now there are three questions attached to the abductor pollicis longus is supplied by which nerve? Radial nerve. Abductor pollicis brevis is supplied by median nerve. Abductor pollicis longus inflammation along with extensor pollicis brevis occurs in decurvent tenosynovitis. And in Bennett and Ronaldo fracture, the first metatarsal is pulled away by which muscle? Abductor pollicis longus. So these are the three things you have to remember. What is boxer fracture? That is the base of fifth metacarpal injury because boxers hit like this. So it is the fracture of the base of the first metacarpal. So I've told you Bennett fracture that is pulled by EPL, abductor pulses longus. If there are two or more fragments, that is involved fracture. So this was the first part, and in the second part, I will discuss pediatrics, ortho, then oncology part, and other remaining part. That will be also 2 hours lecture, and then you can solve more than 90 questions. Thank you.